All right, everyone is still getting connected, so I will give you a second to get you all online and connected. I would love to be able to see as many of your faces as possible. We're so glad that you're joining us for this program today for our care partners and adult children as we are discussing, understanding, and accepting the changes of your loved one. My name is Anissa Mitchell. I'm with PMD Alliance, and I will be your facilitator with Dr. Broman today. And this is a program that we're doing to honor our care partners. It's actually November is National Family Caregivers Month. I don't know how many of you knew that, but this is our second care partner focused program we've had this month. And first of all, I want to take a minute and just thank everyone that is serving the role of a care partner in whatever function that is. We thank you for all of your love and care and compassion for your loved one. The second thing is I want you to scroll at the bottom of your screen and pop up your chat box. And that is where we want you to either ask your question, or if you have a question that you would like to verbally ask, we invite you to just say, hey, I want to ask a question out loud. Give me your name. We'll pop up your name actually. And then I will call on you because there's so many of you joining us today. It's hard for us to scroll through and see who's raising their hand. So instead, if you just want to say, I would like to ask a question, then I will call on you because we want this program to be interactive today. We're going to be talking about some of the symptoms that can be challenging and complex for care partners to manage that can impact your well-being. And we know that as the disease progresses, things can be a little more complex, can be a little bit harder for care partners to balance caring for their loved ones' needs and taking care of their own, and sometimes even put aside their own needs because they are focused on the loved one's needs. So we're going to be addressing some of those things. We would love and invite you to share your concerns, the emotional aspects of dealing with some of these things. I don't know that we get enough opportunity to really talk about them. So this is your chance and your opportunity to talk with them, with Dr. Broman, and just share your experience. So I want to, first of all, before we get started with some of the topics that we want to cover today, I want to introduce Dr. Salima Broman. Many of you know her as one of our physician partners. She's a movement disorder specialist in California. She's been on many of our programs, and you know what a kind and compassionate physician she is. So Dr. Broman, I'm so glad that you're with us today.
Thank you. I'm so happy to be here. Thanks.
Awesome. Well, I want to dive in. And I think I want to start with some mobility issues. So I would love it if you could kind of start giving us a little bit of look into issues related to falls, aside from the expected gait changes or the decreased mobility that we might see. What are some other issues or causes of falls?
Sure. So, falls in Parkinson's is very common. There are lots of reasons, as you know, there's the decreased mobility, there's freezing of gait, there are blood pressure issues that can affect people and with PD and falls. But I think things that we don't think, or we think about it, but we don't talk about it often enough, is how that impacts the caretaker. And what that does to the person that loves a person with Parkinson's every time their loved one falls. I think, from my own patients and their spouses, it's almost as though it takes a little bit out of their psyche and their life every time their loved one falls. Thankfully, most of the time, they don't get too right. It breaks your heart. I get you. I mean, thankfully, they don't, by the grace of God, get too injured. I mean, they get bruised and whatnot, but I think it just chips away at a person's soul, and it makes for a very nervous caretaker. And it sort of comes in how the person with PD, even though you try to say, be careful, do this, do that, but things change. And I think that's what we're going to get into here in terms of what the person is and how the person is versus who you are and what you're doing, and that prevention of falls. I mean, of course, we really want to, continue with regular physical therapy. We want to invite an occupational therapist to come to the house and evaluate things and make sure there's not, regular carpets and things like that that could trip up people. But we really need to sort of take a deeper dive into what we as a care partner can do in terms of every time that happens, and it's going to happen, what can we do about that? There are a few more tips. I don't know if anybody wants to comment yet any other comments. Would you like to share experiences?
And it can be physically demanding when someone's loved one falls, not just the emotional toll that it takes, but when someone actually falls and a care partner tries to help them or maybe get pulled down with them. So there's risk of injury to both of them. Can we talk a little bit about like some of the things that you've recommended to your patients and care partners?
Absolutely. So, it's, even if you were 25 and you had a spouse or a parent or grandparent with Parkinson's that fell, you really want to not try to pick them up. And unfortunately, I see people who are care partners who are in their 70s or 80s trying to pick up their loved ones. And we really want to try to discourage that. Of course, it's a natural instinct. It's someone you love and you want to help them get up, but you're going to wind up risking, as Anissa said, injury to yourself. So you want to try to avoid doing that. The other thing that you want to do is use resources around your community. There are communities that we have the fire department. I encourage everybody to have one of those, the 911, so that you can call the fire department immediately once somebody has fallen, and then assess the situation. Try to stay calm as much as it's so difficult to do so when you see your loved one fall. Try to stay calm, make sure that they're okay, and call the paramedics to help you get them up. But you not to do it yourself. It's too much. You can hurt yourself. And that is definitely something that I have seen, especially with the frequency that people with Parkinson's do fall. It's not advisable at all for care partners to try to help them get up by themselves.
And I like that Nancy wrote that her husband has agreed to wear shoes and not walk around in socks, but occasionally we'll forget, which is understandable if you have hard surface floors that can be really slippery. And you mentioned too, Dr. Broman, like having an occupational therapist come in. Yes. And that's a great idea. And in fact, getting therapy ongoing can be helpful just to keep the mobility and strength up. And they can even train people how to fall better, right. I guess.
Get up better. Absolutely. Yes. So they can help so that a person isn't like falling like a tree trunk, so that you're falling better, as Anissa said, and also giving tips so that a person can get to a situation where that they can get up. So in other words, perhaps you could help move a chair, and they can teach you and your spouse how to safely get up. So Denise is writing something here.
And additionally, I believe they, with a therapist that will come into the home, they can talk to you about maybe just even the way the home is set up. Absolutely. Things that might be fall hazards, and where certain devices or things that can be placed that can help with mobility and safety, especially, in those places that people tend to fall more, in the bathroom.
Absolutely. And I'm very, very lucky. I have a practice where I actually go to my patients' homes if they so choose. And it's amazing how when we think that things are safe, but when you go in and you see, it's glaring how how some things are very unsafe. And it's very important that you ask your doctor for an evaluation from an occupational therapist and a physical therapist to come in and evaluate your home for safety, and making sure that things are arranged properly so that they're not having an increased hazard for your loved one.
So yeah, and definitely if somebody's dealing with any kind of dementia or memory impairment, coupling that with some mobility issues can be an added challenge. Correct?
Most certainly it can. Absolutely. And that's very frustrating as well for this care partner. And even if they don't have a mild cognitive impairment or a dementia, people with Parkinson's tend to see themselves in different eyes than we see them. They think they stand straight. They think that that their balance is okay. So they will get up quickly and walk when we realize that it's not safe, and they don't have the insight sometimes to know that. And it's very frustrating as caregivers to watch that happen. It's very frustrating. Being a caretaker is a tough job, but you need to be kind to yourself, and definitely take care of yourselves as well. It's a very tough job.
So you mentioned something that leads me to another question, and I love Ali's comment. Yes, Superman syndrome.
Yes,
definitely. Before I get to my next comment, I was just going to say, I'm going to even say that care partners can also, from a different perspective, have Superman or Superwoman syndrome, thinking that they can and should do everything, and they need to be reminded that you might be a superhero, but you don't necessarily have superhuman strength. So that's why it's important to take safety measures and take care of yourself as well. So I'm glad that Ali made that comment. I also want to go back to where I started to go before I kind of got the squirrel there, and talking about the slowing down a little bit. So not the bradykinesia, but like slowing people down, and that impulsivity that you might see because they don't necessarily have the same insight. So I know that I've heard other care partners in other programs talk a little bit about, their loved one wanting to quickly get up and do things, or they're wanting to do multiple things at one time. That can be problematic, such as like trying to talk while they're also chewing, which can be an issue, or while they're walking, they're also trying to look and talk to you, which can increases the fall. So can you talk a little bit about that?
Yes. So, multitasking is something in PD that tends to go away. And many people with Parkinson's were, previously very high functioning individuals. But as it progresses, that ability to multitask does go away. And so they don't recognize that they can't hold, two bags and, walk and open the door and do all these kinds of things without it becoming a hazard. And it's frustrating because it'll lead to other things. As you mentioned, talking and chewing can lead to choking and aspiration. Holding a couple of things when they have problems with balance, bags, happens all the time, coming in from the garage and they're holding bags and then they trip and fall. Their postural instability, they can't catch themselves like we could, or they once could. And it's very challenging, but I think trying to slowly remind them, as long as they don't have the cognitive issues, or gently trying to have someone else taking some of that away from them. The multitasking is something that goes by the wayside in PD, and just reminding everybody, them and yourselves, that that's not something that they can do as the disease progresses, and it can be very much a safety hazard.
And I invite people to make comments or even ask questions related to this, but the more that the care partner has to either prompt them, or assumes a task because maybe the multitasking thing is not in their abilities, those weights, those just kind of keep tipping, a little higher, a little heavier for the care partner, a little lighter for the person that, is dealing with the diagnosis. And that's hard on both fronts, because we have someone now that's taking on more and just getting a little more stressed out, and often don't even realize how much they're doing until they hit that tipping point. Meanwhile, the person may be giving up tasks and, feel a sense of frustration around that. So
most certainly. And that's a very great point, Anissa. I think we need to realize whether it's slowness because the person can't do it as quickly, or it's a safety hazard, of course, and we want to, take on things because of the fact that it could be a safety issue. I think it's important to let the loved one with Parkinson's maintain as many activities as they can safely, so that they have their independence and their integrity and their dignity. I think Parkinson's takes away so much from the family, but the person with Parkinson's as well, as you all. But if you can give them or leave them with things that they can continue to do safely, that is going to minimize how much you keep getting on your plate, and let them be happy as well. If you notice some of your loved ones with frustration issues, a lot of it is all of the independence that they've had to give away as well. And that burns inside. A lot of people with PD are so stoic, and they're such kind people, as are you, the caretakers. And nobody wants this, but I think it's so hard. It's such a big pill to swallow, to have this condition where slowly things are taken away. And so the more that a person is kept with what they can do, I think is the best for everyone.
So Liz wrote in, my husband's still very active and exercises and stretches every day. Good for him. He has always been able to do things around the house and has been very capable. You mentioned the PD person sees themselves differently than others. Is this a characteristic of PD? My husband seems to think he can still do house repairs and projects, but they get started and then go nowhere or are extremely slow. He's very resistant to hiring people to do things around the house, which is very frustrating for me.
Yeah, that's really quite typical. It's almost as though there's a time warp. Certainly there's the bradykinesia. Things are going to be slower in Parkinson's, but I think allowing them, not if it's going to drive you insane, but allowing the time that it's going to take for him to complete the task, it gives them something to do. It gives them a sense of independence, and something to look forward to as well. But I understand the frustration. I really do. I think also it is a characteristic, from what I've seen in 15 years of treating people with Parkinson's. They just don't see, whether it's a physical thing or a mental thing. There is a point at which they do see that they slow down, but that's also something that they have to sort of accept, and it's hard. It's part of a grieving thing that, depending on where the person is in their disease, it takes a while. It really does.
Yeah. And Liz followed up and saying, we're talking years to complete a project. So when you're trying to negotiate something like that, because maybe it's something that needs to get done and you can't really wait, do you have any recommendations or things that you have found successful in your experience?
Yes, I would pull in an adult child to sort of like speed things in. And that way it's not like, oh, Bob, I don't think you're capable of doing this, but Joe, my son, Joe, why don't you help work with dad or spend some time with dad, etc. if you have any adult children. Oh, what if you don't have children? Okay, good point. Maybe, well, here's another thing, perhaps putting a time limit on it if it's something that really needs to be done. The other thing is, uh, people, you could point out how long it's taken. If it's something like Anissa said that needs to be done, then just say, well, you know what, it's been this long. We've waited. We sort of need to get this part done. Why don't you work on the next project? And sort of a bargaining type of thing, and that might work.
Okay.
Tricky.
So another thing, and you kind of alluded to this earlier, and that was like the chewing, the slowing down so you don't aspirate. So I do want to talk a little bit about swallowing, because that is a huge thing for people. It's a huge risk for hospitalization, and it's fairly common in Parkinson's. So can you talk a little bit about swallowing issues, aspiration, and the potential for hospitalization, and even the impact on nutritional intake?
Sure. So, the swallowing mechanisms in PD are pretty complex. So there's, of course, the chewing aspect, the tongue, the slowness of the muscles of chewing, and then the esophagus and the motility of it going down. So there's a lot of factors there that can influence our ability to swallow and to do it well. People, once they start coughing and there's signs of swallowing and choking, should be evaluated by someone, a swallow and linguistic therapist, and eventually be tested for this with like a modified barium swallow, or fiber optic endoscopy evaluation as well, to see what's going on, and then be given some tips. Of course, you want to, because these things happen, they eat so much slower, and it could take an hour or more to have a meal, and everybody else is completely done. So that too can cause, like, well, I'm just going to stop eating, everyone's done, what's the point? And then the person with Parkinson's is going to continue to lose weight, and that's going to become a nutritional problem as well. So meeting with a nutritionist would be really important to get a baseline, make sure that they're getting all their nutrients, sufficiently provided for them. And then, of course, their medications, and are they being effective because of the fact that they're having all this slowness to get those oral pills where they should be going. So there's a lot of complicated factors here, but to start with a swallow evaluation from a speech therapist, and then to get those tests done. And they really should be done on a yearly basis. We certainly don't want anyone who's having coughing issues while they're eating or drinking to go without any testing. They are at risk of having an aspiration pneumonia, whereby the food goes down the wrong pipe and then it goes into the lungs, and then this can cause an infection. This, of course, would be an infection in the lungs, and then the person winds up being hospitalized. And we don't want anybody with Parkinson's in the hospital. So that's an issue that we need to really think about and be on top of. So while I know that, you all know this, when the doctor asks their patient with Parkinson's, how are you doing? And the patient says, I'm fine, and they're not fine, and you all are going, no, that's something that should definitely be brought to the attention of the physician, either between appointments, during the appointment, whenever. There's also drooling. That is another problem that can occur, and that too can be problematic, not just for person with Parkinson's, but also the caretaker. And it becomes quite messy and socially embarrassing for the person with Parkinson's. And there's ways around these kinds of not what we call non-motor symptoms. And a lot of it also can have to do with whether or not the patient is on sufficient medications, and if their medications are being absorbed. So certainly something that needs to be addressed with the physician.
So we had a couple people write in. One wanted to know if you could address pocketing of food. And then another, tips for not spilling it. So they don't have tremors, but they're just not close enough to the table and the plate.
Yeah, so in terms of the pocketing, that has to do with the muscles of the tongue and propulsing the food back. So they'll just pocket it in their mouth and it'll just sit there. So that's another reason why people should have an evaluation with a speech therapist, and they can give tips on how to, to sit up, to take sips of water, to do chin tucks, that kind of thing. Very, very important that patients with Parkinson's get those kinds of evaluations. And in terms of the second one was what, Anissa?
Oh, tips for not spilling the food.
Oh,
So
yes. Right. So it's people with Parkinson's have visual spatial problems as well. So they may either put their glass, like not quite get it onto the table. They may take their fork and not quite get it into their mouth, not because of tremor, as you mentioned, but it may be a visual spatial issue. So the first thing I would recommend is having the person be seen by, if you have availability, to be seen by a neuro-ophthalmologist. So somebody who specializes in vision and its connections to the brain, not just an optometrist that makes glasses. That would be really important to see. Perhaps could there be special glasses made for the person with Parkinson's to help alleviate those kinds of problems.
And you mentioned the drooling, and I know that that's not only an issue for the person with Parkinson's and feeling comfortable going out and about, but it has been an issue for couples too. Like, it can be in some cases addressed. There's some treatments for drooling. Is that correct? Because I know that there's care partners that, like, I want to connect intimately with my loved one, but we really need to address that drooling.
Absolutely. I mean, during intimacy, people I've had wives tell me that they want to be intimate with their spouse, but the drool is a barrier to that. And so we do have treatments that are available. There are, some people use drops that will sort of dry up the mouth a bit, but those can cause some side effects, especially cognitive side effects and constipation. So in my own practice, I don't really use those, but they are available. And then the FDA did approve some botulinum toxin to the parotid glands. So the salivary glands are the parotids, the submandibular, and so we have these glands, and if we put in a little bit of Botox into these glands, they can dry up that saliva enough so that the person isn't having so much in the way of drooling. And that's important too, because people can also aspirate on too much saliva as well. So it's an important thing to discuss with your doctor, with your healthcare provider as well.
And going back to the motility issue, somebody wanted to know, how do you know if someone's absorbing their medications? So could you talk about that a little bit?
Sure. So, if they're not absorbing it, basically if a person has been on levodopa for a while, and let's say they're taking it at 8 and 12 and 4 and 8, and they are due for their dose at, say, 12, and let's say at 11 they're starting to have their symptoms starting to show back, whether it's tremor, whether it's slowness, whether it's they're cognitively funny, whatever their symptom is. If that starts to come back before their next dose, then they probably are having symptoms of wearing off. And then that would be a good indicator that they're not absorbing their medication, or something needs to be done. And that happens and about 50% of people at 5 years of having been on that kind of therapy, on levodopa therapy, and about 90% after 10 years. So it's very, very frequent. It happens for several reasons: the levodopa, the way it works, and also the GI system of a person in Parkinson's changes a lot. So it's certainly worth having a conversation with. And we have ways of bypassing the oral routes to get us over that hump, if need be. So certainly worth the conversation with your healthcare provider.
And just real quick to go back to the Botox, they want to know, how often do you have to have those redone?
Yeah, every 3 months.
Okay. Right. So another issue is sleep issues, and they run the gamut with Parkinson's, whether the care partner is getting punched or kicked or, shaken out of bed at night because they have REM sleep behavior disorder, to their loved one up constantly for urinary issues, to insomnia, to you run the gamut here. And that's a lot of stress for the care partner,
Huge.
because they're not getting sleep. So can we talk a little bit about the sleep issues and the impact on the care partner, and some things that they might need to consider as far as some treatments for that?
Absolutely. So sleep is huge. Sleep is important for all of us. If we don't sleep well, we don't function well. I know, there's so many things that can happen to a person with Parkinson's at night, right? So the first is identifying what it is that is happening with the person with Parkinson's. Is it insomnia? Is it REM sleep behavior disorder? Where the person acts out their dreams and hits the care partner, being you, or walking around, or falling out of bed. So REM sleep behavior disorder has its own treatment, and we usually start with melatonin, and if that's not enough, then we would add something called clonazepam. But looking at it through a care partner's eyes, it's very hard to think about how one could relax if there's the threat of being hit in the middle of the night. So it's very, very important that one brings that to the attention of either the healthcare provider, or see a sleep specialist to get some help with the REM sleep behavior disorder. It's not uncommon at all with people with Parkinson's. Actually, it's very common. And it needs to be addressed, because it can be a safety issue for not just you, but also the person with Parkinson's. So super important. Insomnia, there's reasons why people with Parkinson's don't sleep. And so I always think, well, what is that reason? Is it stress? Is it that they're stiff and they can't turn over? Do they have pain? Do they have tremor coming back? Do they have to get up and go to the bathroom? Whatever the reason is, it's going to affect you, the care partner, who's in bed with them. And so that's another thing that one needs to think about and delve into with your healthcare provider. Treat the root of the cause. And we do have treatments for this. If it's something like stiffness or pain in the middle of the night, or having to go to the restroom for 6, 7, 8 times at night, we have medicines that can help all this. So there's not really a reason why a person should be up that many times. But we need to also remember that once if they're not completely, better, then, and you're still getting up several times at night, it really is worth, if possible, having a respite for you, whether you can get someone, an adult child, to stay at night, whatever you can do to get a good night's sleep. Because if you're not able to sleep and you're up all night and you're up all day, you can't possibly be there for your loved one and be in your right state of mind to do the things that you want to do with them the following day. So, we think about, maybe using earplugs, or maybe moving into another room, bed rails, those kinds of things. But it's certainly something that needs to be absolutely addressed and looked into. I always think about finding the root of the cause, but also how is that affecting your sleep? And you can't just be there right there monitoring it all the time, because you will lose yourself in that as well.
And a lack of sleep can cause obviously increased stress, but it's tied to depression. Isn't that true?
Absolutely. Depression, anxiety. And then if you're too tired, you're depressed, you're not going to want to work out, you're not going to want to go for that walk. You all need to take some time for yourself every single day. And then you're going to be sluggish and not want to do that. You're going to be depressed. People start to gain weight. They start to feel like so anxious. They start to stress eat. And then people feel bad. And it's just a cycle that starts to go. But sleep is exceedingly important. We all need it to rejuvenate and feel better.
And to be able to make decisions, to have your brain function up, properly. And, if you're the one making a lot of the decisions, you need to have that rest so that you actually can safely make all of those decisions, and I know it's hard when maybe there's a limited support system, you don't have adult children around, or even if they are, maybe they're not able to assist. You may want to consider like talking to a social worker or an aging life care associate that can help you look at some of the options that are available to you, because each person's situation is different, and kind of come up with a game plan. We tell you to take your oxygen first because you need it in order to be able to take care of them. But sometimes there are barriers to doing that. So it's spending the time talking to somebody, kind of really looking at, what is within your abilities and your resources in order to help you help your loved one. And we've had a couple of questions. I'm going to go back to those. One of them, let's see here. This person wanting to know their mother's in a facility. They give her 0.5 milligrams of clonazepam before bed, but she has no problem falling asleep. But then the nursing staff tells them that she still sometimes have bad nights. Should I ask them to increase the dose? I mean, it can be really difficult, especially in some of these facilities if they have lower staff. If they're in a situation where they're taking the meds, but they're not really enough, I mean, is it a matter of increasing, or are there other options to addressing that?
So again, it really just depends on why she's not sleeping, right? So that's a perfect example. So we use clonazepam not as a sleep agent, but for REM sleep behavior disorder. So for people who are acting out their dreams and such. But for someone who's having, say, insomnia and not able to sleep, I would perhaps use something different based on why the person is not sleeping. So are they anxious? And then that would be something different. Are they waking up and being anxious and having lots of things going on in their brain? Is it because she wakes up and she's stiff? Maybe she needs more dopamine. So it really just depends on what the root of the cause is. And then from there, that would drive the therapy.
We had another person asking, it's not really related to sleep, but their loved one has the closed eye syndrome, the pharospasm, and their eyes are closed most of the day. Is there solutions to that outside of Botox?
Oh, I was going to say Botox.
Yeah.
Botox works beautifully. Yeah, that's the way to go.
And where are the injections? They want to know. Where did those get placed?
They're around the eyes.
Okay.
Yeah. And it's just like 5 of them around each eye.
So another person wanted to know, because we're talking a lot about symptoms as the disease progresses, but can you talk about symptoms that are caused by the medications themselves? So maybe things like impulse control disorders, things like that.
Yeah, of course.
Mm-hmm.
So So impulse control disorders are not uncommon. They occur in about 17% of patients with PD. It's really important to have the lines of communication open with your loved one. I can tell you that I ask my patients at every single visit, and sometimes I just get a year later, Dr. Brillman, I need to talk to you and I need to talk to my spouse. So it can happen, but know one thing, the person really feels like they have control over the situation when they absolutely don't. And it's really not their fault. It is the connections of the dopamine. So whatever the cause may be, whether it's excessive spending or gambling, whatever the case, and it could be several things. It could be sexual promiscuity. It could be lots of different things. It's really not them. It is the way in which the medication is working with them. And the most common culprits of medication are the dopamine agonists at the higher levels. It's not to say we should never use them, but at the high levels, that's where we would see them mostly. And it's not to say it can't happen with anything, it can, but that's the most common. So something that you should have an open, communication with your loved one as well as your healthcare provider.
And I have come across situations where maybe it's not a full-on impulse control disorder, but more of a fixation on certain activities to the point where they're not bad, but they become fixated, and then it's hard for the care partner to get them to do anything else.
Absolutely.
Very intrusive into their daily routines.
Most certainly. And that is something that needs to be brought up as well, because we can do things, we can dial down things, we can add a medication that can help temporize that. So, many people with PD, and this is a generalization, but many people with PD have sort of type A personalities. And so then you add on to that some dopamine and whatnot. And then we've got people sort of compulsive, like, I need to make lists. I need an Excel worksheet. I need this, I need that. And then, so maybe something that isn't so bad, as you said, like I want to work on my programs on my computer. But now it's like, okay, well, fine, you've done that, but now it's dinner time. Can you come for dinner? I'm still working on it, or puzzles or something that's, relatively innocuous, but it's really affecting sort of the quality of life between the two people. So again, very important that one brings that to the attention of the healthcare provider, because we can provide a medication or something to help temporize that will improve your quality of life and your spouses, because they don't recognize that their mind is like closed into this, whatever it is that they're doing, puzzles. I've got the puzzle people, I've got the people that are, working in their garage and their partner can't pull them out. So yeah, it happens, and it happens with frequency.
And Lori wanted to know about sugar. Is that an impulse control issue, or is that just related? Because I hear a lot of people, even if they weren't sweet tooths before getting their Parkinson's diagnosis, that all of a sudden now they've become a sweet tooth.
Yes, I've had a handful of those as well. And I've had it in both senses. So like with a dopamine agonist, I had someone going and getting donuts in the middle of the night who never ate like donuts ever. So, and then I've had people who have wanted more sweets, who never wanted that before. So it can come in all flavors. It really can. It's just when it becomes a huge problem is when it's a problem. So, and if it's in moderation, it's not a disorder. It's okay. But again, we don't want people becoming, diabetic and having issues because of these things.
And I'm going to move on here in a minute, but I want to go back to, since we're talking about impulse control disorders, that there can be occasions where there's secretiveness about some of the sexual related ones, shame, fear, lots of different reasons. And sometimes care partners don't even necessarily know until, they happen to find that their loved one's doing something unusual. So looking for like some unusual behaviors, but it's important for us to talk about this because it causes a lot of strain for the care partner. Whether it's they're getting constant requests for to have intercourse, or they're doing other troublesome behaviors.
Yes. And it's a hard topic. It really is. And it's, again, not something that is usual for that person. And again, I just say, have open communication with your partner and also with your physician or your healthcare provider, because without that, and you may think you may be able to dodge and handle it, but it's very stressful. It really can be, and it can be exhausting. But also recognizing that it's driven not by your loved one, it is the disease. And so, like hallucinations, it's part of the disease. So bringing it to the attention of your healthcare provider, we can help to calm those things down and take the burden off of you, because it will be on you. And those are very stressful parts of PD that don't need to be solely on you. They just don't.
So I'm going to segue a little bit from that to other mood or behavior issues. And Elizabeth had asked about depression and distinguishing it from grief, just, situational grief over the loss that's caused by the disease. And I want to stick in there apathy, because these mood changes, whether it's apathy or depression or anxiety, is difficult for the loved one, but it's really hard for the care partner who's trying to help them do all the things that they need to do, whether it's exercise, socialize, even eat. Sometimes if they're depressed, they may not want to eat. So can we talk a little bit about that?
Yes, of course. So apathy is something that is, I think, and I've seen, is much more bothersome to the care partner than it is for the person with Parkinson's. Apathy is this not having any motivation to do things that one might otherwise have loved to do. So if a person was a golfer or loved to see their grandchildren, now I don't care if I don't really care. That's different than depression. They can sometimes coexist, but I think it's the apathy that sort of bothers the care partners more, because they want to encourage them to go to the gym or to do this, that, or the other, where the person with PD, they don't really have that oomph to do it. And again, that's part of their disease. I'm not trying to make excuses for the person with Parkinson's. I'm just trying for you all to recognize what's part of the disease, so that you can bring that to the attention of the healthcare provider and get the tools that can be done to help this. Yeah, and then of course depression is. Sorry, go ahead, Anna.
Oh, it's just, no, you can go ahead, because I wanted to tie that grief into it. So, how much do you see in terms of grief in the person with Parkinson's versus maybe the grief in the care partner? And grief can be experienced by both, because the care partners may be grieving the person that they had known and loved, and all the ideas of what they would be doing at this season of their life. And that is certainly a situational grief, obviously. And then, the person with Parkinson's or the movement disorders can also have grief. And sometimes it's hard to distinguish what's grief and what's depression.
Yes. Well, and I think that also depends on the person, the people, and their baseline personalities. So I've seen a lot of patients who, some of them, basically, when a person gets a diagnosis, in a lot of ways, they're in denial. And then the care partner is sort of in shock. And then they sort of, the shock wears off, and then usually the person with Parkinson's is still in some bit of denial. And then there's the grief period. And I think both people do go through that grief, this loss of, okay, here we were waiting for the golden years, and now the golden years are not golden, or may not be golden. And so there is grief. There's also the grief of the loss of independence that the person had, and lots of different emotions that people are having. And I think that is something that I hope that people recognize, how important it is to have someone to talk to. A lot of people have been married decades, and decades, and you're married to your best friend, and you always talk to people, to the person. But it's important to be able, because of the frustration, the sadness, the guilt, all these emotions, it's important to have an outlet of someone else to talk to. Maybe it's someone at your church, or it's another person whose spouse has Parkinson's, or it's your neighbor. But that has to come off of your chest, for you to feel better. And it's okay. All of those emotions are okay. And it's will help you in healing and feeling better, and give you the strength to be a great care partner that you are, but not to fatigue. I don't know if I answered your question.
You did. And I'm so glad that you talked about, the importance of talking to other people and just acknowledging some of these emotions, because whether they're changes and frustrations related to the disease symptoms themselves. And, I've talked to care partners before where, they're just worn down, and like they're tired of constantly up at night and cleaning, and they start feeling overwhelmed and resentful, and then they feel guilty for that. And it's this vicious cycle that they can't get past. And that's a really hard place to live. And so if they don't feel like there is an opportunity to step outside of that for a minute, deal with those emotions, because they're normal.
Yes.
And they're understandable, and they're a part of the experience. They can't refresh in order to do all the tasks, whether it's even getting some additional help in the home, if you can, talking to somebody about that. But that's so important to have community. It's so important to understand where you are with those emotions, and not judge yourself for them, but acknowledge where they are and what they are. And then talk to somebody like Kelly put up there. We have a family PD community that meets every Thursday. We have Getting Real Online, and those are videos, but we have a chat group in there. And then there's a Real Talk group that meets. You may have a support group for care partners in your community. That's great. Maybe seeking a counseling, or even going to your clergyman or somebody like that. Just someone where you can feel safe to just get out and not judge yourself for having those. I love David's comment, wish there was a pill to enhance or restore insight, because that's really frustrating when you feel like your loved one doesn't get it and you feel like you're nagging, and that nagging weighs on you too, because you just feel like it's going in one ear and out the other, but you have to do it. So it's draining to have that constant vicious cycle.
Exhausting, right? It absolutely is. But please be kind to yourselves, because, being a care partner is so incredibly difficult, but it's the care and the love that you give, and that means so much. And but you have to be kind to yourselves. You really do, and take care of yourselves, because without that, you can't be there for your spouse or your loved one. You just can't. So take and use whatever resources you have available. I mean, PMD Alliance can help in many ways to help guide you to find the resources in your area, but use them, because you need that. It can be so exhausting, and you cannot lose yourself in this. If If you can get an hour, 2, a week, whatever you can get, take it. You need it. If it's 5 minutes to sit in your car and listen to music or look at a tree or take a 5-minute walk, do it. You need to do something kind to yourself or yourself every single day to rejuvenate. You really do. And
I'm so glad that you mentioned that, because we actually have a special little gift for all the care partners on the program today. And if you pre-registered, you probably already received it in your confirmation email. And if you didn't receive it beforehand, you're going to get a follow-up email after today's program. And it is our care partner well-being cards. And it's just that we recognize that we can't always do self-care. We can't get away for hours on end. And, you know, sometimes that's just not reasonable in our life circumstances, but you can take 5 minutes. And so these little well-being cards are, you print them, if you can print them and then cut them out and pull one out a day. It's literally things that you have space in your day to do. They're reasonable, but those are things that actually can rejuvenate you a little bit. So I'm glad that you said that, because that is actually true. I mean, even if it's 5 minutes a day to go outside and breathe in some fresh air and watch a sunrise or a sunset, something like that really can restore your soul. We have about 3 more minutes, and I just wanted to see if there were any other questions that people wanted to ask before we end out our program today. I know we've had a lot of them that we were not able to get to, or we kind of got to, but if there's one more question, or even Dr. Brillman, if you have one more thing that you would like to share with the group before we close out.
I do want to say one thing. I think, you know, what I've noticed in the past decade and a half is that care partners, being who they are, don't ask for help. They feel like they just give, and that's part of the makeup of who you are. But it's okay to ask, and please ask. If you just need someone, if your spouse or loved one is in that sort of clingy time in their journey, and you need a break for a half an hour, and you have an adult child or a grandchild or someone who your spouse trusts, use that person so that you can go to the grocery store or whatever makes you happy, just to have that little bit of time. It's okay to ask for help. It really, really is. And I know a lot of people, they find it very hard, but you need it. You do. We all do. So take it.
Absolutely. And someone wanted to know if there was anyone else out there that loved one has an atypical Parkinsonism. Yeah, those are not exactly the same as Parkinson's in terms of you know, the treatment plans. And so we do include those in any of our communities and groups that we do. But if you want more information, you're welcome to reach out to us at info@pmdalliance.org, and we can help direct you. I want to thank you so much, Dr. Brillman, for this conversation today.
Pleasure. Thank you for inviting me. It was my pleasure.
And I want to thank everybody else that's here joining us for this program today. We probably could talk another whole hour on a lot of these subjects. They're really important. I want to thank all of you for everything that you do every single day. Look for the email if you didn't get it before, so you get your little well-being cards. And if we could give Dr. Brillman just a wave of gratitude for her time, this expertise that she shared with us today. And I want to thank all of you for joining us and being a part of this conversation. So we hope you have a good rest of your day.
Thank you all. Take care.
Bye-bye.